are excited today to welcome Dr. Maeve MacMurdo from the Cleveland Clinic with us today. Dr. MacMurdo is a staff physician at the Cleveland Clinic Respiratory Institute. Her focus is, and her research is focused on the impact of environment and exposure on pulmonary health. Dr. MacMurdo's primary research goal is to utilize mixed methods, patient-centered evaluation of exposure in combination with advanced spatial modeling to better understand the interaction between individual exposure and environment across disease states and reduce health disparities driven by exposure. Today, she will talk about a few tips for a successful community-based research partnership and how researchers can engage and participate in their own communities, and possibly how to plan realistic timelines in community engaged research work. I know a lot of us kind of struggle sometimes with those late night and weekend events. So we're excited to dive into that topic as well. And for those of you who are not familiar with the CTSC of Northern Ohio, welcome. Science Cafe is a monthly kind of webinar series that we've been hosting through our workforce development module. Typically, our presenter is Mackenzie Ritter. She is the director of our workforce development activities, learning and education, our Atlas program. And I probably should have introduced myself. I'm Laura Parent. I am the Director of Strategic Partnerships and Research Development, and my goal is to help us connect with our partners across all of our institutions as well as our community members.
Hey.
But essentially, our goal at the CTSC is to improve the health and equity of people who live in Northern Ohio and beyond by providing resources and services to our hospital and university partners, our clinical and translational researchers and scientists, and our community members. So we are doing this by focusing on 5 key areas and initiatives. So one being our resources and services, providing education, resources, events, training opportunities aimed at developing the next generation of clinical research professionals across all disciplines. So ranging from high schools and colleges to community and rural settings and our academic medical centers. Community engagement, building trusted relationships and integrating Northern Ohio communities, especially from underserved and underrepresented communities, into all stages of the research process, and providing platforms to community members to collaborate with our researchers and medical providers that directly impact their care. Our workforce development module, providing education, resources, events, training opportunities such as these aimed at developing the next generation of clinical researchers and professionals. Our clinical and translational funding opportunities, we've got a couple opportunities. I will do a quick plug for our annual pilot that is currently accepting RFAs, as well as our themed pilot focusing on integrative medicine that's also available for application. And of course, always our vouchers that are available. And then lastly, but not least, our health informatics by exploring, deploying, supporting, and expanding how to effectively utilize new technologies, data systems, and innovations that improve healthcare to accelerate medical discoveries. These include optimizing platforms such as Trinetics, Cosmos, Epic, and integrating AI into research and scientific innovation. We also have an update quarterly webinar coming up in November on a Cosmos kind of database intermediate session, as well as our datathon in December. So all of those and more on our website, but I don't want to take any more of your time. And I want to hand it over to Dr. MacMurdo, who will be filling us in today and taking some of her time. So thank you so much for being here.
Thank you for having me. And let's see if I can share my slides. This is the first challenge. All right. Are you seeing an actual slideshow?
Yes.
Look at that, victory. So as it was mentioned, really my goal today is to kind of to give an overview of what I've learned as an early career researcher doing community engaged research, and kind of highlight some things that I wish I'd known earlier on that I've learned along the way. And then I'm also going to provide an update on some of my Element E funded research and really talk a little bit about what I'm doing with my research and funding from CTSC and kind of where community fits in and kind of where the needs and gaps are to hopefully get you excited about occupational exposures and farm worker health, which is where I spend a lot of my time kind of advocating and gently harassing my fellow researchers to get more involved in. This is going to be fairly short. I plan for around 25 minutes, and there's time for questions at the end, but also questions along the way. And I really would love to spare dialogue if we can. I know it's harder on Zoom. So if you have points where you want to jump in or interject or ask questions, feel free to raise a hand or just unmute and shout. I think, again, this is kind of better as a dialogue if we can do it that way, but we'll play it by ear. Couple of disclosures first. So I think I want to be really upfront that when I'm talking about this, again, I am not an expert. I am not an emeritus. I am an early career researcher who's been doing this work now for a couple of years, but is still really learning as I go. And I feel like a lot of community engaged work and community engaged research is really an act of kind of just constantly learning and figuring out that you probably didn't do it this right the first time, and it's going to be a little bit iterative and take some sort of error along the way. I'm also not specifically focusing on community-based participatory research or CBPR, which is really its own sort of beast. I'm going to talk about it, but I am not a CBPR professional. I think it's probably worth kind of just flagging that a little bit because that has its own theoretical groundwork that I'm not going to necessarily cover in detail today. So why are we talking about community engaged research and why is community engaged research so important? I think we all kind of recognize that historically academia has not done well by communities. And there's been this really long-standing sort of tradition and pattern of really the helicopter researcher who is based in their ivory tower in the academic center, who will come into a community when they have grant funding, who will do the research and then kind of just leave again. And when the funding dries up, the researcher isn't there anymore. That's been the historical model, and that's obviously not ideal for a lot of reasons. One, it doesn't make good research, and B, it really leaves communities feeling like they're only valuable when there's grant funding on the line, and they're not really getting the information they actually need to make their health decisions. When you think about kind of how long it takes to get data and research from academia into kind of clinical practice, there's a huge delay. And that delay is even longer when we think about how long it takes to get research from academia to clinical practice to the community. Again, dissemination is a huge part of research. And with this helicopter-based research model, we really don't feature that. It doesn't happen. And so communities have this research done to them, they engage in this research, and then don't get the benefits and don't get the health impact that we're trying to achieve. So community engaged research really tries to kind of bridge that gap and actually work with communities as partners and bring in communities as a key part of the research team from the get-go so that we aren't just coming in and coming out and coming in and coming out, but there really is this ongoing dialogue and ongoing communication about what the needs are in the community, what the strengths are in the community, and really how we can help as researchers, while also empowering communities to kind of take the lead on doing their own research and kind of generating their own knowledge. Again, it's kind of this partnership and cyclical back and forth relationship. When we think about kind of how community engaged research works, it really falls along a spectrum. So investigator-driven research is really the kind of opposite of community engaged research. That's the kind of classic bench model of an investigator has a question, does the research, often in the lab or in a sort of in a clinical setting, publishes the results, and it is very much in that academic silo. Community targeted research is one step we sometimes think about where the investigator may involve the community, often in recruitment, so sort of partnering with a community partner to recruit, but the community is not necessarily involved in the actual research itself. They're not involved in dissemination, and they're not really involved in shaping the question. They basically are brought in at the last minute to help with recruitment, but they're not necessarily actually part of the research team. Community engaged research is where I mostly fall, is basically trying to bring the community in as part of the research team. So basically providing input on the research topic, the focus area, having community members as part of the research team on the funding and on the grant, on the papers, having the community members potentially help with actually recruitment, with dissemination, but not necessarily functioning as a sort of full research team. And then CBPR, so community-based participatory research, really where we all are trying to aim to get to, is really where this is a fully collaborative model. So the community picks a topic, the topic is iterative, the research is ongoing and iterative and really community driven, for a process where the community really drives the research rather than the researcher driving the research. There's not necessarily a right or wrong answer for kind of where your research should fall. And I think it's important to recognize that sometimes the CBPR-based model may not always be appropriate for some questions. So again, it's not that one is better than the other, but there's different scales in which community can kind of be involved and be engaged. What is important, and what I kind of get on my high horse about frequently, is that community engaged research is not just including a community advisory board on your grant. That's something we see a lot, where someone will have a sort of very traditional research aim with a community advisory board, and it's helpful. But a CAB alone does not make a research project community engaged, and certainly does not make it CBPR. There's really more to it than that. And it's really important that the community is not just sort of a token, but really a part of the actual research process and research team to actually have community engaged research. So when I think about why I use community engaged research methods and kind of the benefit to me, I think there's a couple of things. One, the reality is that when we think about kind of how to get the most impact and how to be the most helpful, really, our goal of all research is to improve the health of people we serve. And so to do that most effectively, often it's easier to start with an existing framework rather than building something from scratch. Again, if the work is already being done, it makes sense to partner rather than go and try and do your own thing without really the knowledge of the context and the background of why things are being done a certain way. I think it's also really important to recognize that a lot of the time, the barriers to health that we see in the sort of clinical setting aren't necessarily barriers which really actually impacting health the most. I do a lot of air pollution-based research, and I think, again, air pollution is a really classic example where, as an air pollution researcher, obviously I'm really worried about air pollution. I think about that as an impact on health and as a driver of health disparities. My patient in the community who may be exposed to air pollution but also can't afford their medications, who can't get to the doctor, who's worried about losing their job, the bigger barrier to health really isn't their environmental exposures, but all those other sort of micro factors which really impact their individual health. And so developing an intervention that doesn't address those is likely to fail. And that's where having community input is really important, because it lets you avoid those potholes that aren't necessarily visible from the sort of big picture, but really have a huge impact on health in the community level. I think really importantly, and why community engaged research can really help, is that this really gives you a direct pathway for dissemination. And the goal of really community engaged research is that from the get-go and from the start of the research, you're thinking about how you're going to disseminate the work and really at what stage and how throughout the research you can disseminate this work to kind of make sure people are A, aware of what you're doing, B, that it still makes sense to do what you're doing, and see that once the results become available, once you start to get data, you can sort of share that back and build on that to kind of keep that collaboration going and keep the community engaged and move things forward. And by having community engaged from the get-go, again, you've got a direct pathway to let that happen organically. It's not coming in at the end and presenting at a town hall. It's really you being present and you sharing your results as they occur and kind of getting excited about this as it happens in real time. And it is way more fun. It's nice to do things where you can actually see the impact. I love working with the community. I think I've experienced things that I otherwise would never have experienced, like Cinco de Mayo, our festival we had on the 5th of May, with wrestling. Again, there's a lot of things that get you outside your comfort zone that you wouldn't think about unless you're actually out there and doing it. As someone who's thinking about community engaged research and kind of thinking about those first steps, I think there's a couple of really important things to consider. And the first is really considering what your why is. So when you think about the research question that you are thinking about, why is that important? And why should your community partner care about this, work with you on this, and really having a clear answer of kind of why it matters before you start thinking about how to tackle the problem. I think one thing that I recognize and that I realize is that when you think about people who are actually out working in the community, these community organizations, often they're trying to do a whole lot of things with very little budget, and they're juggling multiple competing priorities. And so if you're going to go out and say, hey, I need you to help me with this, I want to partner with you on this, it helps to have a clear vision of what that's going to change and why that matters, to really help them figure out whether that makes sense for them to be involved in your work and to partner with you, because sometimes it may not, or they may have another organization which is a better fit for you. But if you know what that why actually is, that kind of helps to shift that focus. It's also really important to not just approach this as a, hey, I'm a researcher, I've got my idea, let's do it, but to really come with questions about what actually makes sense, what's been done before, and what your community partner sees the barriers as being before you sort of set in stone your research questions, set in stone your aims. Thinking about, again, the barriers that you may see may not be the barriers that are actually important. And having that dialogue before you decide on the research mechanism can really help to both strengthen your research and strengthen its impact. The biggest thing that comes up with community partners and sort of the frustration is that often, again, research is grant funded and grant funding is cyclical. And very few of us have the luxury of being continuously and constantly grant funded. But what I've heard from my community partners is it can be really frustrating when people reach out only when they have funding, and then once the funding is gone, sort of ghost and vanish. And so it's really important to think about, when you can, making connections before the funding's available or independent of funding, and to stay active and stay engaged even when the funding ends. Again, it's not always feasible at the same level, but recognizing that this is an ongoing relationship. It's not just a matter of having funding, doing the research, and again, vanishing back to where you came from. It's really thinking about how you can stay engaged in that community and really foster that seed relationship to kind of build more long-lasting, more fruitful collaborations that really extend beyond just one grant, but really promote, health of the community. And it's also really important to be upfront and open about what your actual goals are. If you're aiming for a publication, you are aiming for a publication, and it's okay to say that. If you want to get grant funding, it's okay to say you want to get grant funding. But again, it helps an organization to really understand where you're coming from and what your priorities are and kind of how engaged you're going to be if you can share really what your hope is. The other really important thing, which often I think gets under-recognized, is thinking about how you can promote your community partner and really uplift your community partner's work. Again, your community partner is often doing really exciting, really impactful work. And part of that collaboration is using your platform, using your microphone to really share the work that they're doing, to promote the work that they're doing, and to make sure that they get opportunities with other researchers and other collaborations beyond just you. You don't want to hog your community partner and sort of, again, gather them all for yourself, as silly as it sounds. But it actually is really important to think about how you can help people engage and share more broadly. Because once the relationship's built, it only gets stronger with sharing. And I think there's definitely room to, again, really promote and highlight the cool work people are doing in this space. Northeast Ohio is a really exciting area. There's a lot of really great groups doing really great things. Often it's hard to kind of figure out what they are because everyone is so siloed and everyone's in their own field. The more you promote and share and kind of promote, activate and highlight, the more that becomes easier to bridge and the more cross collaborations we can achieve. I talked about timelines. I think timelines are a thing that I wish I'd known about when I was starting out in this work, which is that the reality is that the timeline in community engaged research is not really a timeline. It's more of a loose estimate of what might happen with everything going according to plan, because things change. Again, politics happens in real time. Things like hurricanes happen in real time. Communities have emergencies and other priorities and other things which are active that they're dealing with. And so the sort of academic calendar timeline often doesn't really fit well with the world outside of academia. Particularly for smaller organizations, you often find that the sort of post-award period has a lot of logistical hurdles. So literally, how are we going to get you the money? How are we going to get you on the IRB? Do you need to complete some kind of city training, some kind of additional research training to get you IRB eligible? What does that look like? These are all hurdles that can be bridged, but they often take longer than you think they will. I think double is a fair estimate of how long things are likely to take. And recruitment will often occur in sort of this patchy fashion where you'll have a great wave of recruitment, then they'll sort of go dead for a little bit, and a great wave of recruitment, and they'll go dead for a little bit. And that's normal and okay. Again, things are happening outside of the research. I think that's the thing that can be frustrating sometimes when you've planned out this beautiful timeline of how you're going to recruit and what's going to happen. And then the reality of the actual work is completely opposite of that because life happens and is not entirely in your control. I think funders are increasingly recognizing that and recognizing that community engaged work does require some flexibility. but it's still hard to kind of fit sometimes into the traditional NIH reporting framework where things do kind of happen at their own pace. The IRB is a really important piece, and I think it's really important, again, thinking about really partnering with, on an equal level, your community partner, to have them engage in the research as much as they possibly can be, including on the IRB if it's at all possible. It's not always, but I think it's a really important thing, especially thinking about when you're getting this preliminary data back, when you're sharing this data back, when you're kind of trying to interpret and figure out what this means. Having someone who really knows their community can kind of provide that input is really useful and really valuable. And the more the IRB will let you do that, the better. Budgeting is also really important, both in terms of how much things are going to cost, recognizing that when you're trying to recruit people, their time is valuable, and it's really important that you recompense their time appropriately. But also that for these small organizations, which a lot of community partners are very small, there's not a lot of staffing flexibility. They don't have 5 people just waiting in arms to kind of take up this research. So anything that you ask them to do or anything you partner with is potentially going to get in the way of the primary mission or may impact the primary mission. And so it's really important that you budget appropriately to really make sure that doesn't happen. So you can support their staff and support the work they're doing and make sure that they're not suffering financially because of this, or that they're having to sacrifice things that they otherwise would do for the community that they've been doing because the research takes more time or requires more effort or requires more man hours than you thought it would. And so I think being generous with the budget and really from the early stages, kind of one of the first items you plan for should be how much you're going to reimburse your community partner and how it's going to work. Also thinking about logistics of when you're going to reimburse. So making sure that you don't have invoices that are unpaid for weeks and weeks and weeks, making sure there's a streamlined pathway for how things are going to be paid, where you can, taking the weight of having to carry unpaid invoices off of them and sort of onto your own institution is helpful too. Again, we have more flexibility than a lot of these small community partners do. I think it's really important to recognize that. A $1,000 invoice not being paid for Cleveland Clinic for 2 weeks is not a big deal. For a community organization, waiting 2 weeks for $1,000 may be a really big deal budget-wise. And so just thinking about that and really being mindful of that from the start is going to go a long way to really maintaining a community partnership. People do not schedule their day around the academic calendar. And I think it's really important to recognize that the vast majority of community engaged work is going to happen on evenings and weekends. There's really just no way around it. This is a photo from some of the work we were doing a grocery store-based recruitment mechanism, which I'm going to talk about a little bit shortly. But again, when you think about when our farm workers go to the grocery store, it was Friday evenings. And so for that summer, I spent most of my Friday evenings in a grocery store backroom doing data collection. And that was lovely. It worked beautifully. But when you think about kind of the timing and what your institution may recognize as your service time, that's often happening outside those traditional hours. It's very much not 9 to 5. And in fact, it's almost never 9 to 5. It's almost always weekends and it's always evenings, which is reasonable. But again, recognizing that from the get-go and thinking about how you're going to facilitate the resources you need to do this research successfully in terms of coordinated time, in terms of translator time, in terms of technician time, in those evening and weekend hours is really important from the get-go to really build a successful timeline and make sure research goes smoothly. I also want to highlight something which I think is really important, which is that we often talk about community engaged research as though we're sort of separate from the community, but the reality is that we are all also a community and part of communities. And I think it's really important when you think about community engagement to actually just be engaged and to truly think about what's going on in your own community. And when you can, just turning up. I've made a lot of connections for research and for life just by turning up to things that weren't research related, but you meet people who are doing cool things and you talk about the cool things they're doing and the cool things you're doing, and collaborations build organically from there. And the more people know you and know that you do what you say you do and that you're actually a part of the community, the more people trust you to be part of their community. I think it's a really nice cycle where the more engaged you are, the more engagement you get. And so where you can, if you're not sure how to find a community partner, if you're not sure about what community engagement looks like in your research, just turn up to stuff and go to events and see who you meet and see what you find out. And often that's really valuable, both from a life standpoint. Often those events are free, it's great for kids. And also I think it really is rewarding because you actually are part of the community you're doing the research in, and that goes a long way. There are a lot of really, really great resources out there, and I wanted to just promote and talk up the Cheer Institute at Metro, who has a fantastic toolkit, the Brace Toolkit, which is a really great resource for people who want to get started in community engaged research and maybe aren't sure what that looks like or how that works. But Corey has some fantastic research resources too. Again, I put the link there, I can share that if people are interested. And then CTSC also has the Community Engaged Research Caller, who are a really valuable research resource and have a lot of great options for consultation if you're thinking about this but really aren't sure how to get started. I was going to change focus now and talk about my farm worker research, but Laura, I'm not sure, do you want to take questions now or should we go for a dual?
Yeah, there's a couple questions in the chat. So from Sanjay, what are major challenges that you have faced performing community-based research? We'll start there.
I think the biggest one was figuring out logistics. And so Cleveland Clinic is a monolith of an institute. It's great. I love working there, but our IRB was not used to community engaged research. And trying to explain to the IRB that no, I was not bringing patients into clinic. I was going out to the grocery store. Took some took some wrangling. Basically, for everything I do, the IRB emails me 4 or 5 times and goes, "Are you sure you're doing that?" And I have to explain that yes, I am, and that we're not going to collect any information. We're not going to collect SSNs because my patients are undocumented. And there's a lot of sort of back and forth with the IRB. That's gotten better, but I think IRB is a major hurdle to community engaged research, which is often under-recognized. And it gets better, but it's a lot of work.
Yeah. And how can we better engage the community for research studies?
So I think that's another one where it depends on what you mean. And I think, a lot of the time community members are busy. Like people have a lot of other stuff they're doing. I've got a toddler, and quite frankly, I don't have time to fill in a survey. And if someone asked me to, I'd really have to have a good why for why I was doing it. And so I think if you want community to engage in research, you really have to think about what people actually get out of it and what it means for them and what they're giving up to do the research. And if the answer is a lot and a little, then people probably aren't going to do it, and that's not unreasonable. It's again, I think the community partners can be really helpful.
Yeah. I think one question that you've kind of made me think about is, obviously you want this to be a mutually beneficial relationship. And a lot of times community partners maybe have felt burned or slighted by, former involvement or historical events that have occurred that have deterred them from trusting institutions. And, maybe they've seen cases of institutional bias in their communities. Are there any tips to rebuilding that trust and, kind of proving obviously every case is unique, every study is unique. How do you repair things that have been broken? Is that on you as the researcher, or is it something else that we can do?
It's a really good question. I think it has to come from multiple angles. I think one thing that you can do as a researcher, which can really help, is literally just showing up for things. And I think when people see that you turn up, even when you aren't getting something out of it, that can go a long way. It takes time, and that's not something you can do overnight. I think a lot of the relationship building really is, it's slow. Where it can be helpful is, again, having a community partner who can introduce you, or a research partner who can sort of be an introducer and sort of say, hey, I know you've had this experience, but here is Laura. She's not like this. Here's what she wants to do, and I vouch for her. And again, those community relationships really go a long way to strengthening that sort of historic mistrust and kind of breaking that cycle. But I think once that happens, it's also really important that you don't screw up, quite frankly, and that you really think about how you're going to make sure that that doesn't happen again, because it's really easy to make mistakes. I think everyone recognizes that mistakes happen. No one expects you to be perfect, but people do expect some transparency, some back and forth. And I think historically, the research community has been really bad about coming in and doing research, then not kind of talking the talk long term. And that's changing, but that takes time.
Mm-hmm. Yeah, thank you. If anybody else has any questions, feel free to unmute or drop them in the chat. Lydia writes in the chat, there is a community alternative to for community partners that has accepted with justification. So the CTSC resources. So the certification center
Yeah.
for,
It's great. It's a really good resource. Hang on. Let me just quickly, someone's knocking my door. Give me one second. I'm so sorry.
That's okay. Lydia, did you want to elaborate on that at all?
CWRU has accepted it as city certification, and it's an excellent course. I took it and it takes about 4 hours, so it takes about as long. Oh, Dr. MacMurdo, excuse me for going ahead. Laura said to speak. So it takes about 4 hours, and it's very, very pragmatic. Like, it's really training about how to seek informed consent and what ways you word things could be misconstrued as coercive. So it's just really pragmatic. And I actually thought it was an excellent training. It's less theoretical and academic than city, but you do need to justify it to the IRB, like, why are you doing this? And typically what they've told me is that after a year, they would consider that individual to be eligible, so to speak, for the usual city training, and that this is more of a bridging certification, but it could be helpful, like for a community health worker or someone who's going to be with you for a shorter period of time, potentially. And honestly, they said they would make me switch them over to city in a year and didn't. So I'm not sure should be saying that, but
wow, they're going to find out.
Right. So anyway, yeah. Thanks for, I think the idea that you gave, somebody else said too, of just coming to events is just excellent, because then you are one of the community, not studying the community. So that's great advice. Thank you.
Thank you. I love that resource. I've used it a couple of times, and it's free, which is fantastic, because city can cost money for a lot of our community partners, which is not ideal either.
Yeah. Well, great. Well, why don't you go ahead and tell us a little bit more about your work, and we'll continue on.
Okay. So changing tack slightly, they're not all that much. So I kind of mentioned earlier that most of my work really focuses on health disparities, particularly thinking about our farm worker community. And I think thankfully, or I guess, am I still sharing my screen? Yes. So what we've really seen in the past couple of years is increasing awareness that climate change is happening, and that wildfire smoke and air pollution exposure is really this growing and pressing issue, not just in the West Coast, but in California and the East Coast, kind of throughout the United States and globally. When you think about farm workers and farm worker health, again, this is an extremely vulnerable worker group. We know that more than 20% of farm workers really live below the poverty line, and they are largely excluded from federal labor laws. When we think about the farm worker population in the United States, increasingly we're seeing a shift from traditional patterns of migrant farm workers, or sort of farm workers who have come to the United States and lived there permanently, to farm workers coming in for the H-2A guest program, which is basically a sort of temporary work visa that ties a farm worker's employment and their visa status together, meaning that their employer controls where they live, what they eat, where they work, and whether or not they can stay in the country. As you can imagine, that means that farm workers are extremely vulnerable to worker exploitation and have a lot of barriers to advocating for improved workplace conditions, which we see in the data. Farm workers are 20 times more likely to die of heat-related illness. They've got a 7 times higher workplace mortality. And when it comes to even accessing services like healthcare, because of language barriers, the vast majority are Spanish-speaking only, farm workers really are excluded from accessing even things like Medicaid, like OSHA. Despite all we know about how farm workers are dying, we really don't understand farm worker health, and there's been really very little research looking into the impact of these exposures on farm worker health more broadly or more long term. We know that farm workers are at risk for respiratory disease. Again, they're exposed to a number of things which are tied to occupational lung disease, including pesticides, to agricultural dust and silica, and increasingly to air pollution. And so there's really a concern that exposures are happening, and we don't really understand what that's doing to the health of our farm workers who are already so vulnerable and so exposed. So we started off doing a community engaged project looking at the impact of ambient air pollution on farm worker health. And I partnered with an organization called OLA, which many of you may be familiar with. Veronica Dahlberg is amazing. And she is really advocating for farm worker health in Northwest Ohio, and has been since the get-go. And she shared my concern about these exposures and really what this is doing to farm workers, and was worried that we didn't understand what was really happening in Ohio. Again, Ohio has a large farm worker population who often goes unrecognized, and there's very little health data about our farm workers. And so through funding from Metro, we were able to do a pilot study looking at basically exposure to ambient air pollution using a technique called local knowledge mapping. And we did this by going into the grocery store and spending time in a grocery store back room where the farm workers were brought once a week to basically buy their groceries. So they had no transport, they couldn't leave their farms, but once a week they were bussed out to this grocery store and were there for about 2 to 3 hours. Veronica knew this, and so she got me in and got me in the back room, and we were able to recruit 96 farm workers over this harvest season using a technique called local knowledge mapping, which really lets farm workers mark out on paper map where they're spending time, what fields they're working in, and then using satellite drive models to basically model out the air pollution exposure from the sky up. These are young workers, so a median age of 28, who've been working since they were pretty young. We saw a median of 4 years of agricultural exposure, and respiratory symptoms were extremely common. About 1 in 5 had persistent wheezing, 14% had cough, 21% had rhinitis, but despite that, really only 1 had ever seen a doctor, and no one really knew whether or not they had asthma or COPD. Again, this is a population with very limited access to healthcare. We saw significant symptom differences of reporting by gender. So women were much, much more likely to report than men. And we suspect a significant underreporting, which I'll touch on a little bit later. But when we looked at the exposures, we saw that, again, this is a highly exposed worker group. 68% of worked in a field where pesticides had been sprayed or applied, 15% had actually applied pesticides themselves, 7% had been poisoned at least once by pesticides during their working career. And again, this is a median work employment of 4 years, so this is happening more than we want it to. More than 2/3 lived in what we call crowded housing, defined as more than 2 workers per bedroom. So most of these workers are sleeping in bunk beds, with often 2 to 3 workers in one room. Despite all these other exposures, their exposure to ambient air pollution was actually relatively okay, with a mean exposure of 7.3 micrograms per meter squared over sort of summer and winter season. So not high level ambient air pollution exposure. When we looked at what we found, we did not see a relationship between exposure to ambient phenotype and respiratory symptoms, but we did see a strong link between pesticide exposure and an increased risk of respiratory symptoms, which resolved when adjusted for age and gender. Again, this is sort of helpful and unhelpful. Basically, to kind of summarize, we saw a lot of respiratory symptoms, but couldn't really pinpoint it to one thing. And when we thought about what that could be and kind of what was happening, we realized that really, again, these people were being exposed to more than one thing at once. It wasn't just a single exposure driving this. And when we look at sort of satellite drive models versus what people are actually exposed to, we see some really important differences. Particularly thinking about the actual work of agriculture and what's involved. Those satellite drive models may not really capture what workers are actually experiencing on the ground. And most importantly, we realize that when it comes to sort of cultural expectations around reporting symptoms and reporting illness, there's a lot of hesitation, particularly from our male farm workers, to really report their symptoms and to complain. I got some really good quotes from some of these farm workers about, I don't get sick, I'm not a complainer. And that was really the predominant cultural of like not complaining, of not getting sick, because if you got sick, you potentially couldn't work and couldn't come back to the United States the following year. So there are major barriers to self-reporting. And so with this data, we aim to kind of move beyond this and really try to understand respiratory health. And we did this by trying to bring spirometry to the grocery store. This is a photo from data collection a couple of weeks back with exhaled nitric oxide, this little thing here, and a Go Spiro, and again, the grocery store back room. This is through funding from CTSC Element E. And so really what we're trying to do now is move beyond self-reported symptoms and think about how we can actually quantify true obstruction and true spirometric measures of lung function impairment in our farm worker community. So we're using exhaled nitric oxide, which is basically a measure of airway inflammation, along with portable spirometry, which can measure things like obstructive lung disease and restrictive lung disease, and assessing this compared to self-reported respiratory symptoms to really try and tease out the difference between what people are reporting and what we're actually measuring in terms of lung function. We're then going to move beyond that and really look at the whole exosome and combination. So looking at what workers are exposed to, both from their housing quality, from their exposure to ambient air pollution using a personalized monitoring device, and other drivers of occupational poor health using the NIH WellBeQ to try and tease out really which of these multiple exposures that farm workers are experiencing are things we potentially address and modify and move towards improving to improve farm worker health. This work is ongoing and active, and what we're seeing so far really fits with what we were worried about. Again, we're seeing a fairly high rate of symptoms, with roughly 18% responding to persistent wheeze, and 9% saying they were so sick that they weren't able to work. No one had COPD or asthma that they were aware of, and while people did smoke, the tobacco use pattern is very different from that we see in the general American population, smoking about a cigarette a day or a mean pack of 0.05, so not a high smoking population. Again, roughly half the samples being exposed to pesticides and actively working with them, and we're seeing exposure across multiple settings in fieldwork, nurseries, and the greenhouses. When we look at PFT data against the preliminary, we're seeing a high rate of obstruction, with roughly 60% meeting criteria for obstructive airway disease defined by FEV1 to FVC criteria, and what looks like a pattern towards airway inflammation with a mean exhaled nitric oxide around 16 parts per million. We are seeing significant variability in PFT quality, and one challenge that we're realizing is, again, thinking about how we coach PFTs and administer PFTs. Doing it in Spanish in a grocery store is really hard, it turns out. And a lot of our technique and our sort of how we coach is kind of being adjusted to really try and improve these results. That requires some iteration because, again, translation is not one size fits all. And what seems like a clear instruction when I try and say it is not as obvious when you're trying to shout it over the noise of the grocery store. So we're working on that. But when we think about kind of next steps and really why this is needed, I think thinking about farm worker health and farm worker health disparities, we know that the lack of data is a major barrier to achieving health equity. We don't know what we don't know. And if we don't look at this population, we assume they're healthy. And what we're seeing is that's really not the case. There's this huge need for policy, but until there's data, it's very hard to push for that policy. And even when there is policy that's in place, there are really these big barriers to how we actually implement policy and make it effective to actually improve health. Farm worker populations aren't uniform, and a lot of the work we've done has really been focused historically in California and the West Coast, which is very different than Ohio, both from a policy standpoint, from a farm working standpoint, and from an intervention standpoint. And really, it's not enough to just tell workers to wear a mask. When we think about both barriers to mask access and barriers to using a mask effectively, if we're seeing obstructive lung disease, that's a major concern. These workers may not be able to wear a mask effectively. And so there's a lot more work that's needed in this space, but I think fundamentally this really supports the need to think about farm workers and to recognize that this is a really vulnerable worker population who's largely been ignored, and that needs to change. I think I'm on time still. I'm going to say thank you. My toddler, as I mentioned, has been very supportive throughout all this. As Mummy goes out to the grocery store, she has no idea what I do, but she knows I'm gone and doing something. My community lung clinic, who's been really great about coming out to events with me and being a presence and being a familiar face, which has really helped to kind of build trust and get our word out there. And then our research team, so Veronica, who I mentioned, Cydia, who's also with Ola and has been fantastic in helping me out with this. And my mentors, Jackie Curtis, Karen Malloy, and Dan Culver, who put up with me most of the time. With that, I can take a second round of questions.
Wonderful. And your daughter is beautiful. Are there any questions from those in attendance? Go ahead, Ash.
Maeve, thanks for a very interesting presentation. I just wanted to share the results of an analysis I did a couple of years ago. I used the Freedom of Information Act to request from NIH the budgets of the last 50 community-based participatory research projects that they funded. And, as you mentioned, community-based participatory research is the sort of the most collaborative type of community research. And I found that lion's share of the funds went to the academic partners and not to the community organizations. So that's something else to keep in mind when you're designing a community-based project, is to keep in mind that how equitable the funds are used is also something that's part of should be part of the thinking about the project.
Fully agree. I think budget is under-recognized and really important.
Great. Other questions? Dr. MacMurdo, I do have one for you as well. How do you in return help promote, you kind of talked about the integral part of making it a very fair and balanced kind of exchange. How do you help your community partners through promoting their efforts as well?
I think Veronica is sick of me promoting her efforts because I've gotten her on the cab on CTSC. So I think one thing that I try and do is to talk up my community partners wherever I can. I mean, people ask for community representation to say, hey, I have this great group that I work with. And so I have volunteered Veronica for many, many opportunities, whether she wanted them or not. But I think it's really important to kind of put people's name out there and kind of raise the profile of what these small organizations are doing. I also budget a fair amount of money for my community partner, which I think as much of my salary as went to theirs, which is good. Like that's what we want, because I realize I'm asking a lot of them. And then the third thing we did was actually budget for an event through our grant. So our Element E grant actually funds a health fair run through OLA every year, which allows us to both disseminate the research and to make sure that the things we're doing to try and promote health equity have a broader impact. So it brings in other organizations, other institutions, and lets OLA host the event and not have to take, again, not a financial hit. They're not fundraising, they're not having to try and work for this. They have the money there, they can do it without having to stress about it. And that's really helped, I think, both get the community engaged and to really see where the problems are. We're seeing a lot of mental health problems, which is something we didn't think about, and I'm not addressing, but is a real crisis. And then a lot of diabetes. And so there's a lot of other work that could be done. I think promoting the health fair and kind of promoting the work that OLA is doing helps to find other community partners who can do that work too.
I think it's critical then you develop some advocates, along the way. And a lot of it occurs naturally too. You see somebody who becomes engaged and interested in the project, and then it makes it a lot easier to help spread the word when you have multiple people and multiple buy-ins from, every direction. So that's really quite helpful. Great. Well, unless there are any other questions, of course, feel free to unmute and chime in. But I just have a couple quick housekeeping items for the remainder of our time here. So again, thank you to Dr. MacMurdo for taking the time today to present. Your background, your information that you've shared is really great. Lots of wonderful resources in your slides and of course in the chat as well. A couple other things that we want to point on. Of course, this is an ongoing webinar series through the CTSC. We've got our community engaged research and community network modules. So, there are opportunities on our website, of course, to engage and go further into what this topic kind of explores and brings to the table with us. Next month, our Science Cafe will be focused on cardiovascular health and cardiovascular health equity with Dr. Sherry Bolin. That will be November 14th at noon. You can scan the QR code and register for that. Of course, if you have any feedback on this session, or if you would like to suggest any future topics, of course, feel free to include that. We've got a brief survey for this session as well. And, we want to just, of course, thank you, Dr. MacMurdo, for your time. And last but not least, become a member of the CTSC. You can stay up to date on our training opportunities, our events, and of course, funding opportunities as well. So Dr. Mackenzie Ritter, she is kind of our lead for all things workforce development, Science Cafe. Her contact information is below, but you can find all that information on our website as well. So I want to check the chat one last time. All right. Well, no further questions. Thank you all for your time today. And the recording will be available afterwards if you want to share with somebody and keep this great work going. So thank you all for your time and have a wonderful day.